Hello everyone, I'm myself Dr. 𝗑𝐲𝐫𝐞. I'm the general medicine educator. So in this particular section, I'll be discussing the quick revision of the respiratory system, that is the pulmonology. So the first important topic for the quick revision is the pulmonary function test. Now what exactly is the purpose of the pulmonary function test? The purpose of the pulmonary function test, it is mainly to differentiate the obstructive lung diseases from the restrictive lung diseases. So that is the important function of or important purpose of making out the pulmonary function test. And in this pulmonary function test, we have the two forms or two methods by which we assess the pulmonary function. One is the dynamic lung function and the other one is the static lung function. Now out of all these, actually we have the various parameters that we test in both static and as well as dynamic lung functions. But out of all these, it is the forced expiratory maneuvers. They are very much crucial for the diagnosis of the obstructive lung disease or the restrictive lung disease. And what are the various parameters that are being measured? So if you take the lung volumes which are being measured, that includes the total lung capacity, right? So total lung capacity is nothing but it is the volume of air which is there in the lung after forceful inhalation. That is what is called total lung capacity. Then we have the vital capacity, then the inspiratory capacity, right? So inspiratory capacity is nothing but it is the volume of air that is inhaled forcefully from the end inspiration of the tidal volume. And residual volume, even after forceful exhalation, the volume of air which is left out in the lung is what is called residual volume. Then next is, if you add the time factor to this inspiration and expiration, then you get this FEV1, FVC, FEV1 by FVC, and as well as the peak expiratory flow rate. So you take this FEV1. So this FEV1, it is the volume of air which is exhaled by the end of the first second is what is called FEV1, right? And it is this FEV1 by FVC which is a very important parameter which will help us to differentiate obstructive from restrictive lung disease. And this peak expiratory flow rate, it is the bedside method for assessment of the pulmonary function test or bedside method for assessment of the pulmonary function. This peak expiratory flow rate, it is measured with the help of what is called peak flow meter. That is what is called the peak expiratory flow rate. Next important is the DLCO, that is diffusion capacity of the lung for carbon monoxide. So if you see the diffusion capacity of the lung for carbon monoxide, this will tell, actually we use the carbon dioxide to assess the diffusion capacity. And the carbon monoxide is the one which will help us to make out or to tell how the diffusion capacity is there within the lung. That is what is called the DLCO. So this will measure about the lung's gas transport capability. That is what is nothing but the diffusion capacity. And if you take the normal volumes, how much is the normal total lung capacity? That is around 6 liters. The tidal volume is around 0.5 liters. The expiratory reserve volume is 1 liter and residual volume is 1.2 liter and inspiratory reserve volume is 3.3 liters. And please remember, your FEV1 by FVC is a very important parameter to differentiate obstructive from restrictive lung disease. And how much is its value? That is around 70%. So FEV1 by FVC is around 70%. Now if you take this FEV1 by FVC in patients with obstructive lung disease, this is less than 70%. Whereas in patients with restrictive lung disease, the value, it is more than or equal to 70%, right? So this is the very important parameter which will help us to differentiate OLD from the RLD. Now coming to the OLD. Now what exactly, okay, so if you take the steps in the interpretation of the pulmonary function test, what is the first step? The first step, please remember, you need to measure the FVC and followed by that you need to measure the FEV1. If at all both the parameters are within the normal limit, the individual is said to be having normal pulmonary function, right? Then the individual is said to be normal. If suppose if the FVC is reduced or if FEV1 is reduced, then you need to take a ratio of the FEV1 by FVC, right? Then you need to take a ratio of FEV1 by FVC. And you need to evaluate for the obstructive lung disease or restrictive lung disease based on the patterns. So these are the steps to interpret the pulmonary function test. And what are the key indicators? The key indicators, as I have said you, it is FEV1 by FVC, which is decreased in obstructive lung disease, whereas it is near normal or increased in the restrictive lung disease. Then coming to the diffusion capacity of the lung for carbon monoxide. So diffusion capacity of the lung for carbon monoxide, if you see, the DLCO, it is considered as normal in extraparenchymal type of restrictive lung diseases, but it is decreased in case of the intraparenchymal type of restrictive lung diseases. Whereas in obstructive lung disease, if you take, in obstructive lung disease, it is decreased in case of the emphysema. Emphysema is an obstructive lung disease, whereas ILD, it is an interstitial lung disease, which is intraparenchymal type of restrictive lung disease. It is DLCO is reduced. So DLCO is reduced in the interstitial lung disease and as well as the emphysema, and it is normal in case of extrinsic type of restrictive lung disease. So that is about the DLCO. Peak expiratory flow rate, this is what I was trying to tell you. So this is the one which will assess the bedside measurement of the pulmonary function, and this is reduced. And how is this measured? With the help of a peak flow meter, and it is reduced in patients with the obstructive lung disease. And another important key parameter is the forced mid-expiratory flow rate. What's an important multiple choice question on the forced mid-expiratory flow rate is, this will help us to determine the smaller airway diseases. This will help us to determine the smaller airway diseases. That's an important multiple choice question related to forced mid-expiratory flow rate. Now, if you take the pulmonary function test pattern, right? So if you take the pulmonary function test pattern, so how will be the normal pulmonary function? So this is the loop which is there above the x-axis, and this is the loop that will be there below the x-axis. So this will be the inspiratory component, and this will be the expiratory component in the pulmonary function test, right? Now, in case of a fixed central airway obstruction, right? So where do you get this fixed central airway obstruction? You take, for example, in tracheal stenosis. In tracheal stenosis, you will have flat inspiratory and as well as the expiratory curve. So this expiratory and inspiratory curves, whatever are there, they will be flat in case of the tracheal stenosis. Whereas in the scenario of variable extrathoracic obstruction, now what is the example of the variable extrathoracic obstruction? That is retrosternal goiter. So in case of the retrosternal goiter, it is only the inspiratory component that will be reduced, because the retrosternal goiter, it is pulled down during the inspiration, it will compress the trachea. So the inspiratory curve is being reduced, whereas the expiratory component is more or less within the normal limit. Whereas in case of variable intrathoracic obstruction, what is the example of the variable intrathoracic obstruction? That is laryngeal tumors. So in case of laryngeal tumors, please remember, there will be flattening of the expiratory curve only. The inspiratory curve will remain normal. So because laryngeal tumor, which is a pedunculated tumor, when during the inspiration, the air which is coming in will ensure that the laryngeal tumor is thrown away to the walls of the trachea, so the airway will be clear. But during expiration, the air which is coming from the lung to outside, it will push the laryngeal tumor towards the lumen of the trachea. So thereby the trachea is being obstructed. So your expiratory curve is flat in case of the variable intrathoracic obstruction. Now, if you observe the obstructive lung disease, what are the various parameters that will be abnormal? One of the very important. Okay, so first of all, what exactly you mean by this obstructive lung diseases? Obstructive lung diseases is that where there is an obstruction during the expiration. So during expiration or during exhaling, the individual will have a difficulty, right? And this obstruction is mainly because of the inflammation or the collapsible airways, right? So due to inflammation or due to collapsible airways, mainly during the exhalation, there will be an obstruction. And what are the examples of the obstructive lung diseases? The examples of the obstructive lung diseases, it includes, like you can just remember the mnemonic as, right, A, 2B and 2C. So A is asthma and B, it is like bronchitis and as well as bronchiectasis. And C stands for the COPD and as well as the cystic fibrosis. Now, what are the pulmonary function test findings in patients with the obstructive lung diseases? one of the very important finding is the FEV1 by FVC. So what will happen to your FEV1 by FVC, that is normal, or sorry, the FEV1 by FVC, it is decreased, it is less than 70%, whereas your FEV1 is also reduced, FVC is also reduced, but FEV1 is more reduced than compared to that of FVC. That is the reason why if you take the overall ratio, the FEV1 by FVC will be reduced in patients with the obstructive lung disease. And peak expiratory flow rate, as already I have discussed, this is the bedside methodology for assessment of the pulmonary function, and the peak expiratory flow rate, it is decreased. Then what will happen to the total lung capacity, residual volume, and as well as the functional residual capacity? So total lung capacity, residual volume, and functional residual capacity, all of them, they are increased, right? All of them, they are increased. And if you take the hallmark of the obstructive lung disease, it is always the expiratory flow rates that will be reduced, right? It is always the expiratory flow rate that will be reduced, okay? And in case of the acute asthmatic attack, what will be the changes in the pulmonary function? So in acute asthma changes, there will be increased residual volume, there will be increased forced vital capacity, there will be increased FEV1, and there will be decreased total lung capacity, right? There will be decreased total lung capacity. So this will be in case of the obstructive lung diseases. The parameters in obstructive lung disease, very important is the FEV. So FEV1 by FVC, it is reduced in case of obstructive lung disease, whereas in case of the restrictive lung disease, like what exactly is the problem? So if you see the definition of the restrictive lung disease, there is restricted lung expansion, right? There is restricted lung expansion, right? So there will be reduced volumes. So the inspiratory volume is also reduced. So subsequently, the expiratory volume also will be reduced in patients with the restrictive lung disease. So there will be reduced volumes, poor oxygenation. Now, if you take the etiology of restrictive lung diseases, we have parenchymal and as well as the extra parenchymal. What are the parenchymal causes? The parenchymal causes will be sarcoidosis, pneumoconiosis, idiopathic pulmonary fibrosis, drug or radiation induced interstitial lung disease. And extra parenchymal, the pathology is not within the lung parenchyma, but it is outside the lung parenchyma. That is kyphoscoliosis, obesity, and neuromuscular disorders like myasthenia gravis, Guillain-Barré syndrome, motor neuron disease, cervical spine injury, phrenic nerve damage, diaphragmatic palsy. So all that will be your neuromuscular disorders. Then what will happen to the parameters in the pulmonary function? So if you take FEV1 and FVC, both are decreased, but here it is the FVC which is more decreased than compared to that of FEV1. So that is the reason why if you take the ratio, that is FEV1 by FVC, it is normal or increased. Why it is normal? In early stages when both the parameters are decreased in same level, the FEV1 by FVC will remain normal. But as the severity progresses, the FVC will be more reduced than FEV1. So thereby your FEV1 by FVC is overall increased. Then what will happen to the total lung capacity, residual volume, and functional residual capacity? See, total lung capacity, residual volume, functional residual capacity in case of OLD, we have discussed that they are increased, but here they are decreased. And what is the hallmark here? The hallmark is decreased volumes or the compliance. There will be decreased volumes or the compliance. And if you take the DLCO, it is decreased in parenchymal disease, whereas normal in case of the extra parenchymal. So extra parenchymal in the sense kyphoscoliosis, obesity, and neuromuscular disorders, the DLCO will remain normal, whereas in sarcoidosis, idiopathic pulmonary fibrosis, the interstitial lung disease, in all those conditions the DLCO will be reduced. So this is about the quick revision of the pulmonary function tests. Now, after having discussed about the pulmonary function test, the next important topic in the respiratory medicine will be the ARDS, that is acute respiratory distress syndrome. Now, what exactly is the definition of acute respiratory distress syndrome? So please remember, it is a disorder which is characterized by diffuse bilateral non-cardiogenic pulmonary edema, right? It is diffused bilateral pulmonary parenchymal disorder with non-cardiogenic pulmonary edema. Okay, and in this individuals, there will be sudden onset dyspnea, there will be severe respiratory distress. There is severe respiratory distress and the hypoxia, right? And hypoxia. So that is what is the definition that you observe in case of the ARDS. And this is often fatal, right? And this requires mechanical ventilation and as well as the ICU admission, right? So this requires mechanical ventilation and as well as the ICU admission, right? So this is a very important respiratory emergency. And if you take the synonyms of the ARDS, the other names which are given is the shock lung or diffuse alveolar damage, acute alveolar injury or acute lung injury. So these are the various synonyms for the ARDS. Then what are the etiologies? So if you take the etiologies, we have direct lung injuries causing ARDS and indirect lung injuries causing ARDS. So you take direct lung injuries. So direct lung injuries causing ARDS will be like pneumonia. So pneumonia is considered as the most common cause for ARDS. And apart from that, aspiration of the gastric contents, then toxic gas inhalation, pulmonary contusion, drowning, these are all the direct lung injuries causing ARDS. Whereas if you take indirect lung injuries causing ARDS, the indirect lung injuries causing ARDS, sepsis, that is the most common cause for the indirect lung injury causing ARDS, right? Then followed by that, the trauma, burns, multiple transfusions and as well as the pancreatitis. So these are the indirect lung injuries causing ARDS, but out of all these, the most common cause for ARDS is sepsis, right? So these are the various etiologies that will be causing ARDS. Now if you take the pathophysiology, you have the exudative phase, then followed by that we have the fibroproliferative phase, then we have the fibrotic phase. So these are the three phases in the ARDS. Now you take the exudative phase. So exudative phase, the duration is around 0 to 7 days, and in exudative phase there are two important changes that occur. What are the two important changes that occur in the exudative phase is, number one, there will be damage to the capillary endothelium and there is damage to the alveolar epithelial cells. So thereby it is the protein rich fluid along with the inflammatory cells from the capillary, from the pulmonary capillary, they enter into the alveoli. So you will have protein rich edema, right? You will have protein rich edema, and these patients, they will have the surfactant deficiency because there is damage to the pneumocytes. So this is what is nothing but exudative phase, where the fluid from the pulmonary capillary is entering into the alveoli. Then followed by that, the fibroproliferative phase. The fibroproliferative phase, this will be there for nearly around 7 to 21 days. And in this, there will be infiltration of the fibroblast and there will be proliferation of the fibroblasts, right? So there will be influx of the fibroblast. Then followed by that, the fibrotic phase. So fibrotic phase, it is like more than 21 days, right? Fibrotic phase, it is more than 21 days. So in case of the fibrotic phase, there will be excessive fibrous tissue, and that is what is causing the hardness within the lung. So you will have a completely stiff lung. That is due to fibrous tissue accumulation, and that is the reason why we use this term called diffuse alveolar damage, where there is fibrous tissue accumulation within the entire alveoli. Then what is the criteria? The name of the criteria for ARDS is, it is the Berlin's criteria. And in Berlin's criteria, like you can just remember the criteria in the form of ARDS, right? Where A stands for the individual has respiratory distress acute in onset, that is within 1 week of the clinical insult there will be respiratory distress. R stands for reduced PaO2 by FiO2, where the value is less than 200. D stands for the presence of bilateral opacities on the chest X-ray, so diffuse bilateral opacities. S stands for the Swan-Ganz catheter measures the pulmonary capillary wedge pressure, which is less than 18 millimeters of mercury, which is normal. So the pulmonary edema that you will have here is non-cardiogenic pulmonary edema. And if you take the CVRT of the ARDS, right? So the basic problem in case of the ARDS is reduced PaO2 by FiO2. In case of mild, the PaO2 by FiO2 will be 200 to 300. In moderate, the PaO2 by FiO2 will be 100 to 200, whereas in severe, the PaO2 by FiO2 will be less than 100 millimeters of mercury. And you have to understand that these patients, they have reduced surfactant, there is the alveolar collapse, and these patients, they are having respiratory distress. So there is reduced surfactant, and in these individuals, there will be increased alveolar capillary permeability. So from the pulmonary capillary, the protein-rich pulmonary edema will be entering into the alveoli. So pulmonary edema with proteinaceous fluid, and there will be stiff lung, that is due to fibrous tissue accumulation. There is reduced compliance, that is also due to fibrous tissue accumulation. And there is hypoxemia in these individuals because the lung parenchyma is replaced by the fibrous tissue. And there will be hypocapnia. Why is that there is hypocapnia? Please remember, in mild to moderate form of ARDS, there will be tachypnea where there will be increase in respiratory rate that will cause the carbon dioxide washout that will result in hypocapnia. Whereas in severe form of ARDS, right? Whereas in severe form of ARDS, please remember, the fibrous tissue is so extensive in the pulmonary parenchyma that the carbon dioxide washout does not occur. So there will be increase in the carbon dioxide levels. Okay. So there will be hypercapnia in case of the severe form of ARDS, and there will be diminished tidal volume. There will be diminished tidal volume. So this will be the clinical features that you will observe in case of the ARDS. Then if you take the chest x-ray, in ARDS, you will notice that there is bilateral diffuse pulmonary infiltrates. Right, in ARDS, you have bilateral diffuse pulmonary infiltrates. And if you take the cardiothoracic ratio, that is normal. The cardiothoracic ratio is not being affected. But in case of cardiogenic pulmonary edema, you will notice that there is increased cardiothoracic ratio. And even the CP angle is normal because there is no pleural effusion. Whereas in cardiogenic pulmonary edema, there will be blunting of the coastophrenic angle. So in cardiogenic pulmonary edema, there is enlarged cardiothoracic ratio. You have batwing appearance due to alveolar edema, and there is blunting of the coastophrenic angle. Now, if you take the complications in case of the ARDS, the complications in case of ARDS, that includes number one, the ventilator related complications. Ventilator related complications are the ventilator related pneumonia, or we call it as the ventilator associated pneumonia, and then followed by that the barotrauma. So these are the ventilator related complications, and then followed by that the ICU related complications, because these patients will be requiring the ICU stay for a longer duration of time, and that can cause the psychosis, deep vein thrombosis, gastrointestinal bleeding, and catheter related infections like catheter associated urinary tract infections. So these are the complications. And how do you manage these patients? As I have said you, these patients definitely require the mechanical ventilator. So on the mechanical ventilator, you have to ensure that the tidal volume that is being maintained, it should be around 6 ml per kg. Right, the tidal volume that should be maintained is around 6 ml per kg, and this particular tidal volume of 6 ml per kg will minimize the barotrauma in the individual. So actually the normal tidal volume is up to 12 ml per kg, but if you keep the tidal volume of 12 ml per kg, there is risk of barotrauma. So that is the reason why you need to keep a low tidal volume in the patients with the ARDS. Now coming to the PEEP. So PEEP that you have to maintain around 10 centimeters of water, and this will improve the oxygenation. And the preferred position of the individual while the individual is on mechanical ventilator in patients with ARDS is the prone position. So this helps in the oxygenation, but the only problem is in prone position there is risk of the extubation, right? And at the same time, very important is you need to limit the fluid intake. At the same time, you need to limit the fluid intake. Okay, so once you limit the fluid intake, this prevents the pulmonary overload. Okay, because these patients with the ARDS, it is non-cardiogenic pulmonary edema. So once you limit the fluid intake, the non-cardiogenic pulmonary edema component will be reduced, right? And prognosis, the most common cause of death in these patients, it is sepsis, right? Most common cause of death in these patients will be sepsis. So this is about the ARDS, that is acute respiratory distress syndrome. Now, after having discussed about the ARDS, the next important topic for the discussion will be pleural effusion. So if you take this pleural effusion, what exactly this means? The fluid which is accumulated in the pleural space is more than the normal quantity. And how much is the normal pleural fluid volume? The normal pleural fluid volume, it is around 5 to 15 ml. So abnormal accumulation of the fluid in the pleural space is what is called as the pleural effusion. Now, in order to detect clinically what should be the quantity of the fluid in the pleural space, so in order to detect clinically the fluid that should be there in the pleural space, it should be around 300 ml. So minimal fluid detectable clinically, it is around 300 ml. Now, on the chest x-ray, if you want to visualize, right, on the chest x-ray, if you want to make out the pleural effusion, in the lateral view of the chest x-ray, if you want to make out the pleural effusion, the quantity of the fluid should be more than 100 ml. Whereas on the frontal view, if you want to make out the pleural effusion, the quantity of the fluid should be more than 200 ml. Whereas CT scan, if you take, CT scan can detect as small as 10 ml of the fluid as well. That is about the CT scan of the chest, right? And if you take the character of the normal pleural fluid, the pH of the normal pleural fluid is around 7.60 to 7.64. The protein content in the pleural fluid is less than 2%, and LDH is less than 50% of the plasma value, and the glucose, it is similar to that of the plasma, and WBC count will be less than 1000 per cubic millimeter. So this is the normal pleural fluid parameter or characteristic features. And if you take the classification of the pleural effusion, mainly we have two types. One is transudate and the other one is the exudative type of pleural effusion. But overall, if you take what is the most common cause for the pleural effusion, the most common cause for the pleural effusion will be the congestive heart failure, right? And transudative type of pleural effusion, this is due to systemic factors. And what are the etiologies for transudative type of pleural effusion? That includes the congestive heart failure and as well as the cirrhosis of liver. And the other etiologies include nephrotic syndrome and even the constrictive pericarditis as well. Then if you take exudative type of pleural effusion, the exudative type of pleural effusion, this is the local pathology, whereas transudative type of pleural effusion, it is due to systemic pathology, whereas exudative type of pleural effusion is mainly due to the local pathology. And what are the local pathologies which will be causing exudative type of pleural effusion is, that includes the infections, right? And the next one is the malignancy. So these are the exudative type of, these are the etiologies which will be causing exudative type of pleural effusion. Now, you need to be completely aware of an important criteria to tell it is an exudative type of pleural effusion, and that is called as the Leitz criteria. So if you take the Leitz criteria, it is considered as the exudate if any one of the following is present positive. Number one, the pleural fluid protein content, it should be more than 3 grams per deciliter, right? The pleural fluid protein content, it should be more than 3 grams per deciliter. That is number one. Number two, the pleural fluid protein to the serum protein, it should be more than 0.5. And if you take the pleural fluid LDH to the serum LDH, it should be more than 0.6 or more than 2/3 of the upper normal serum LDH limit. So that is what is the pleural fluid LDH value, right? So pleural fluid LDH to the top of the serum LDH, it should be more than 0.6, right? Or the pleural fluid LDH should be more than 2/3 of the upper normal serum LDH limit. So out of these three parameters, at least one should be there positive to consider Leitz criteria to be considered as positive, right? And etiologies already we have discussed. In case of the transudative, it is congestive heart failure, cirrhosis of liver and nephrotic syndrome. But the most common cause will be congestive heart failure. Whereas exudative type of pleural effusion, where the pathology is local pathology, the most common cause will be infections, that is pneumonia. or tuberculosis. And even malignancies will contribute to the development of exudative type of pleural effusion, that is bronchogenic carcinoma, and even breast carcinoma as well. Then autoimmune conditions which will contribute to the development of the exudative type of pleural effusion is rheumatoid arthritis and as well as systemic lupus erythematosus. So these are the etiologies that will be causing pleural effusion. Then what exactly is the pathophysiology? So if you take the fluid if you take the fluid in the pleural space, where is that fluid coming from? So it is the capillaries which are there in the parietal pleura, right? It is the capillaries which are there in the parietal pleura. Through that capillaries in the parietal pleura, the fluid will enter into the pleural space, right? And the fluid will go out via the lymphatics, right? The fluid will go out via the lymphatics. So through the capillaries in the parietal pleura, the fluid will enter into the pleural space, and via the lymphatics, the fluid will go out of the pleural space. Now, if there is disruption between the entry and as well as exit, that means if there is excessive entry of the fluid or if there is decreased exit of the fluid, that can result in the pleural effusion. So entry via capillaries. So capillary endothelial rupture. Then the pathology within the visceral pleura, pathology within the peritoneal cavity via the diaphragm. So in these scenarios, there is excessive entry of the fluid. Now coming to the exit. Now if there is lymphatic block, if there is lymphatic block, that will cause the pleural effusion due to exit pathology. So the pleural effusion can be either due to entry pathology or due to exit pathology. And types of effusion depending upon the various constituents within the pleural space. If there is excessive accumulation of pus accumulated within the pleural space, that we call it as the empyema, that we call it as the purulent fluid. And now if suppose along with blood, right, along with fluid, if there is also blood, that we consider it as the hemothorax, that is blood in the pleural space. And to consider it as hemothorax, what is the important criteria? Hematocrit should be more than 50% of the peripheral blood. That is what is called hemothorax. Next one is the 𝐒𝐲𝐿 effusion. Now what do you understand by the word 𝐒𝐲𝐿 effusion? Presence of the milky fluid in the pleural space is what is called as the 𝐒𝐲𝐿 effusion, where you have high triglycerides, right? Where you have high triglycerides. And how much should be that triglycerides? The triglycerides should be more than 100 milligrams per deciliter. So that is what is called the 𝐒𝐿 effusion. So types of effusion, it can be either empyema, right, or it can be hemothorax, or it can be 𝐒𝐿 effusion. What will be the clinical features? Because of the excess fluid in the pleural space, the expansion of the lung parenchyma will not be there, and that will result in the dyspnea. And there will also be chest pain and as well as the cough. Why this chest pain? That is due to pleuritis. And why there is cough? If the etiology causing pleural effusion is pneumonia or tuberculosis, the individual can have the cough. Because there is excess amount of the fluid in the pleural space, what will happen to the breath sounds? So there will be diminished breath sounds, and on percussion you will have a dull note, and the type of dull note will be a stony dull note, right? The type of dull note will be a stony dull note. And what will happen to the tactile phrenitis? Because there is decreased conduction of the vibration to the surface of the chest, there will be decreased tactile phrenitis and as well as decreased vocal phrenitis. So there will be decreased tactile phrenitis. Then what will happen to the trachea? Because of the presence of the pleural effusion, the trachea is pushed to the opposite side. So you will notice that the trachea is away from the affected side. Okay, so that is what is nothing but the mediastinal deviation. And how will you diagnose? The very important method by which you can diagnose is by chest X-ray. So chest X-ray will show you that there is blunting of the costophrenic angle, and that is the earliest sign of the pleural effusion. So the earliest sign of the pleural effusion is blunting of the costophrenic angle. And what are the various other ways by which you can diagnose the pleural effusion? That is by CT scan of the chest and as well as the ultrasound of the chest. And the other ways by which you can diagnose is you need to do thoracocentesis. But what is the purpose of thoracocentesis? There are two reasons. Number one, diagnostic. Number two, therapeutic. So you take diagnostic. So you need to take out the fluid and you need to analyze the fluid. And the fluid will tell you like what type of pleural effusion is this and what is the etiology causing pleural effusion. Next is therapeutic. So where you will be able to make out the treatment. So if the individual is having massive pleural effusion, you take almost up to 1500 ml of the fluid. So that will reduce the dyspnea component in the individual. So that is what is nothing but thoracocentesis, right? Next, you need to do the analysis of the fluid. You need to assess the pH, the protein content, then the lactate dehydrogenase levels, the glucose levels, cell count, and as well as the cytology. So this is about the analysis. So in the diagnosis, chest X-ray is the first line investigation, and that will, the earliest feature will be blunting of the costophrenic angle. Then what are the other chest X-ray finding? You will have the presence of the homogeneous opacity. You have the trachea being shifted to the opposite side, and you have the presence of the Ellis S-shaped curve. Right, you have the presence of Ellis S-shaped curve. And if you take the management, that is the treatment. So as I have said you, thoracocentesis has to be done. Mainly in case of massive pleural effusion, you need to take out the fluid up to 1500 ml per session. And the fluid that you need to take out up to 1500 ml per session, that is mainly to avoid re-expansion pulmonary edema. Right, that is mainly to avoid re-expansion pulmonary edema. Right. Next is chest tube insertion. When is that you need to place a chest tube? Now, if at all, if there is a loculated effusion, or if at all, if there is presence of empyema, you need to place the chest tube in the pleural space, right? And next is the pleurodesis. Now, what do you understand by this word pleurodesis is, and when will you do pleurodesis? You do pleurodesis whenever there is recurrent pleural effusion, right? So whenever there is recurrent pleural effusion, you need to do a pleurodesis. And what are the agents that we use for pleurodesis? That is the sclerosing agents for recurrent effusion. Sclerosing agents for recurrent effusion. So that is about the pleurodesis, right? Then coming to the complications, one is the empyema, right, where you have the infection within the pleural space. Next important is the fibrosis of the lung parenchyma. Next is the respiratory failure. So infection, fibrosis, and as well as the respiratory failure. So these are the complications which are associated with the pleural effusion. And if you take the specific conditions, how will you diagnose the tuberculous pleural effusion? You need to estimate the levels of the ADA, that is adenosine deaminase levels. So adenosine deaminase level, it will be more than 45 international units per liter. And next important is the PCR. So positive PCR for tubercular DNA. Positive PCR for tubercular DNA. So this will be the method by which you can diagnose the TB effusion. Next is malignant effusion. The most common cause for malignant effusion, it will be the bronchogenic carcinoma or the breast carcinoma. Next important is the hepatic hydrothorax. Now, what exactly is this hepatic hydrothorax? Hepatic hydrothorax is that in patients with cirrhosis of liver, there will be right-sided pleural effusion. That is what is nothing but the hepatic hydrothorax, right? So due to cirrhosis of liver, there will be right-sided pleural effusion, and that too a transudative type of pleural effusion. And the other conditions where you can have right-sided pleural effusion is in amoebic liver abscess. There also you will have right-sided pleural effusion. And what are the conditions where you will have left-sided pleural effusion? That is in case of esophageal rupture, and as well as in pancreatitis, and even in Dressler syndrome, you will have left-sided pleural effusion. And right-sided pleural effusion, it is observed in case of cirrhosis of liver, ruptured amoebic liver abscess, and even in case of Meek syndrome, you will have right-sided pleural effusion. So this is about the quick discussion related to pleural effusion. The next important is the pneumothorax. So what exactly is the pneumothorax? It is the scenario which is characterized by excessive accumulation of air in the pleural space. That is what is called pneumothorax. And this particular pneumothorax will create a positive pressure within the pleural space, and that will cause the collapse of the lung. And this pneumothorax, it can be a primary spontaneous pneumothorax or it can be secondary spontaneous pneumothorax. So in case of primary spontaneous pneumothorax, please remember there is no lung disease. Whereas in secondary spontaneous pneumothorax, there is presence of an underlying lung disease, and that is contributing to the development of the pneumothorax. Next is the traumatic pneumothorax. So traumatic pneumothorax, that is mainly due to injury. So that is during insertion of the central venous catheter, right? That is during insertion of the central venous catheter, there can be development of traumatic pneumothorax. Next, when the individual is placed on mechanical ventilator, that can cause pulmonary barotrauma and that can contribute to the development of the pneumothorax. So traumatic pneumothorax. Next important is the iatrogenic. So that is what I was discussing. So traumatic pneumothorax, it can be secondary to the procedures or even it can be secondary to a chest trauma or blunt trauma to the chest. And if you take this iatrogenic, that is following the medical procedures, right? Following the medical procedures. Okay. So in case of the iatrogenic pneumothorax, the etiologies will be insertion of central venous catheter and patient placed on mechanical ventilator causing pulmonary barotrauma. That is what is your iatrogenic pneumothorax. And if you take the etiology of the pneumothorax, primary spontaneous pneumothorax, so it is due to rupture of a subpleural blebs. Secondary spontaneous pneumothorax, it is due to either COPD or tuberculosis or due to bronchogenic carcinoma. That will be, or even it can be a connective tissue disorders like Marfan's or the rheumatoid arthritis. Traumatic pneumothorax, as I have said you, blunt or penetrating trauma to the chest. And iatrogenic pneumothorax, that is either during placement of central venous catheter or during thoracocentesis or the patient on mechanical ventilator. Tension pneumothorax is considered as a very critical condition, and this is considered as a respiratory emergency. And in patients with tension pneumothorax, the mediastinal pressure is elevated so much that there will be decreased venous return, right? There will be decreased venous return. So once there is decreased venous return, what will happen to your cardiac output? That is also significantly reduced. Thereby what will happen to blood pressure? That is also significantly reduced. So there will be hypotension in patients with tension pneumothorax, and these patients will require immediate intervention. These patients will require immediate intervention. So what will be the clinical feature? That is sudden onset dyspnea and as well as chest pain, right? Sudden onset dyspnea and as well as chest pain. And the other important features are the tachypnea and as well as tachycardia. Then there will be diminished chest wall movements, right? There will be diminished chest wall movements, and there will be decreased breath sounds, and there will be hyperresonance. Okay, so chest wall movements are decreased because lung is collapsed, right? And there is decreased breath sounds because the lung is completely collapsed. There is no lung parenchyma at all. And there is hyperresonant percussion note. Why there is hyperresonant percussion note? The hyperresonant percussion note will be there due to excess amount of air in the pleural space. So that is what is called the hyperresonant percussion note. Then trachea will be deviated to the opposite side because the lung is collapsed. The mediastinal pressure is elevated, that will push the mediastinum to the opposite side, right? So the trachea is deviated. So in pleural effusion and pneumothorax, in both of these scenarios, the trachea is deviated to the opposite side. And the chest x-ray will show you that there is increased radiolucency, that is due to excess amount of air. Trachea is being shifted to the opposite side, and there will be hyperresonant percussion note. Okay, so increased radiolucency, collapsed lung, and mediastinum being shifted. And if you take the ABG, there is hypoxemia in these individuals, and hypoxia is the one which will cause increase in the respiratory rate, and that will cause the hypocapnia. So there will be respiratory alkalosis in the ABG. And next is when you do a chest x-ray, the chest x-ray will show you that there is presence of a deep sulcus sign. Mainly when you do a chest x-ray in the supine position, there is insinuation of the excess air into the costophrenic angle, and that we call it as deep sulcus sign. So radiolucent costophrenic sulcus in the supine chest x-ray. So that is about the diagnosis. Next is the management. If you see, if at all, see, the treatment completely depends upon the severity of the pneumothorax. If there is small pneumothorax, just observation and oxygen therapy, that's all. Whereas in moderate pneumothorax mean the volume of the lung which is being collapsed is more than 25%. So more than 25% of the lung is being collapsed, then these patients will be requiring the needle aspiration. And in case of the severe form of pneumothorax, right, in case of severe form of pneumothorax, that is more than 50% of the lung is being collapsed, then we consider it as the tension pneumothorax. And in these patients, the chest tube insertion has to be done, right? Chest tube insertion has to be done, right? And if the chest tube insertion has to be done in the fifth intercostal space, the mid axillary line. That is what you need to do in case of the severe form of pneumothorax. And complications, it includes the tension pneumothorax, which is a life-threatening complication, and there will be subcutaneous emphysema, right, where there is air accumulation beneath the skin, and pneumomediastinum. So pneumomediastinum is that where there will be esophageal or bronchial rupture can contribute to the development of the excess accumulation of air within the mediastinum, that is called pneumomediastinum. And in recurrent cases of pneumothorax, what is that you need to do? These patients will require thoracoscopy or thoracotomy with pleurodesis, or pleurectomy has to be done. And pleurodesis is being done with the help of the chemical agents. What are the chemical agents that are required for doing pleurodesis? That is talc and as well as the tetracycline, right? Talc and as well as tetracycline, they are the one which are required for the pleurodesis. And if you take the precautions, very important is avoid smoking, because 50% chances that there is recurrence because of the smoking. And at the same time, the patient has to be advised to avoid the high altitude. The patient has to be advised the unpressurized flights and the scuba diving. So avoid high altitude, avoid the unpressurized flights and scuba diving, because that can increase the recurrence of the pneumothorax. And how will be the prognosis? See, 30% recurrence after the observation or the tube thoracotomy, but there is low recurrence with surgical intervention. Okay, so once you have done a successful therapy, there is no long-term complications. So that is about the pneumothorax. So pneumothorax, very important in this is mainly the tension pneumothorax, which is a very, very important respiratory emergency, and these patients will require an immediate treatment. So this is about the quick discussion related to the pneumothorax. So the next important topic for the quick revision in the pulmonology is the bronchiectasis. So if you take this bronchiectasis, this is also an obstructive lung disease, and it is the disorder which is characterized by persistent and irreversible dilatation of the medium-sized bronchi. And what is the generation of the bronchial tree which will undergo persistent irreversible dilatation is? It is 5th to 9th generation where this will undergo persistent and irreversible dilatation. And what is the scope of dilatation? The dilatation will be more than 2 mm of the baseline diameter of the airway. And what exactly is the cause for this particular dilatation in patients with the bronchiectasis? The most common cause, it is the recurrent infection. So recurrent infection, that is the most common cause for the development of the bronchiectasis, right? And if you take the etiology that will be causing bronchiectasis, apart from infection, even within the infections also, the most common organisms are tuberculosis, pneumonia, and as well as measles. These are the infections. Then the other important conditions or other important infections will be allergic bronchopulmonary aspergillosis. Then what are the other acquired causes? The other acquired causes include smoking, immunodeficiency disorders, and then connective tissue disorders. What are the immunodeficiency disorders? The immunodeficiency disorders that includes IgA and as well as IgG deficiency, and connective tissue disorders include rheumatoid arthritis and as well as the Sjögren's syndrome. Then what are the congenital causes for the development of the bronchiectasis? The congenital causes include cystic fibrosis and as well as the 𝐒𝐻𝐵𝐺 syndrome. Now in case of 𝐒𝐻-Ginehr syndrome, what are the components? Along with bronchiectasis, there are few other components that you observe in case of the 𝐒𝐻-Ginehr. The components in case of the 𝐒𝐻-Ginehr, you can remember that in a form of a mnemonic, that is ribs. The word R, it stands for the rhinosinusitis. The word I stands for the infertility. The word B is bronchiectasis, and the word S is the situs inversus. So situs inversus is that where the organs will have the transposition onto the opposite side. And if you take the bronchiectasis types depending upon the shape of the bronchi which is dilated. So the shape of the bronchus will be cylindrical, saccular, varicose, and as well as the traction bronchiectasis. So out of all these, what is the most common form of bronchiectasis? The most common is the cylindrical bronchiectasis. Then what will be the clinical features in these patients with the bronchiectasis? The clinical features will be, in the abnormally dilated airway, there will be accumulation of the sputum, right, or there will be accumulation of the mucus, and this particular mucus will be causing the irritation of the airway, and thereby the individual will have the chronic productive cough with the purulent sputum. And the airway which is being dilated by more than 2 mm, the bronchial vasculatures or the bronchial vessels, they rupture, and once the bronchial vessels rupture, the individual can have the development of the 𝐒𝐞𝐻EMOptysis, and on examination these patients will have clubbing. And because there is accumulation of the mucus within the airways, when you auscultate these patients, you have the crepitations, and these particular crepitations, it is the leathery crepitations, right? These crepitations are leathery crepitations, and because of the accumulation of the mucus within the airway, there is airway narrowing, and that will cause the development of wheeze and as well as rhonchi. Then we have a form of bronchiectasis called dry bronchiectasis, which is nothing but the Bronchiectasis sicca, right, which is nothing but the Bronchiectasis sicca. Now what do you understand by this word Bronchiectasis sicca? It's a form of dry bronchiectasis. There is no sputum production at all. Now in which condition you come across this dry bronchiectasis is, it is observed in patients with tuberculosis, post-tuberculosis. And in dry bronchiectasis, what is that you will have? You will have only 𝐒𝐸moptysis. Sputum production will not be there. That is what is called as dry bronchiectasis or Bronchiectasis sicca. Then how will you diagnose these patients with bronchiectasis? Because these patients have copious expectoration, you collect the sputum and you place it in the flask. And once you place this sputum in the flask, you will notice that the sputum is differentiated into 3 layers. So you have what is called a 3-layered appearance, right? You have what is called 3-layered appearance. Now, if you take the chest X-ray in these patients, chest X-ray, the dilated airways, which are more than 2 mm, they will, along with C-shaped cartilaginous rings, they appear to have tram track appearance. They appear to have tram track appearance. So tram track appearance is what is noticed on the chest X-ray. That is a classical finding in patients with the bronchiectasis. But what exactly is the investigation of choice in these patients? The investigation of choice in these patients will be the HRCT. So HRCT, it is considered as the most accurate test. And this particular HRCT, that is high resolution CT scan, this will show that the airways are being dilated, and you will see the presence of tree in bud appearance, right? You will see the presence of tree in bud appearance, and the other important thing is signet ring sign. So tree in bud appearance and as well as the signet ring sign, that is what is being observed on the HRCT. But if you want to visualize the bronchus, then what is that you need to do is bronchography or bronchoscopy. By doing bronchoscopy, it is not that you will only be visualizing the bronchus, you will also plan for the surgery as well. So for surgical planning also, this particular bronchography is very important. Now coming to the complications of the bronchiectasis. The complications of bronchiectasis, that includes the severe 𝐒𝐸moptysis. So these bronchus, whenever they are dilated, the blood vessels or the bronchial vasculature which are present over the bronchus, they can get ruptured, and that will result in the development of the 𝐒𝐸moptysis. And these individuals, they will also have the recurrent infections, and these particular recurrent infections can progress to the development of the lung abscess. And followed by that, there will be amyloidosis, 𝑐or pulmonale. Now this 𝑐or pulmonale, why does this occur? Due to, see, because of the bronchiectasis there is hypoxemia, and this hypoxemia will cause pulmonary artery vasoconstriction and will increase the afterload on the right ventricle, that will result in the 𝑐or pulmonale. Followed by that, these patients will have respiratory failure, secondary brain abscess, and septic arthritis. So these will be the complications that you observe in patients with the bronchiectasis. Then if you see the treatment, because it is the recurrent infections which is causing the bronchiectasis, the mainstay of treatment in these patients will be the antibiotics. And because there is narrowing of the airway due to accumulation of the mucus, you need to give the bronchodilators, and these bronchodilators that we give is beta-2 agonist is what we give. Then followed by that, because there is excessive accumulation of the mucus in the airways, and you have to ensure that these mucus or the sputum is expectorated out. For that, you need to do what is called the chest physiotherapy and postural drainage of these secretions. Now, if allergic bronchopulmonary aspergillosis, if it is the etiology causing bronchiectasis, then you need to give steroids. Then, when is that you can plan for the surgical resection? If the bronchiectasis is localized, if there is no systemic involvement, that is when you can plan for the surgical resection. But in advanced cases of bronchiectasis where there is diffuse bilateral bronchiectasis, in such case you cannot do lobectomy. What is that you need to do is you need to do lung transplantation for the widespread disease, right? And what are the common organisms? So we have discussed that it is the infections which is the most common cause for bronchiectasis. So the common organisms that will be causing bronchiectasis, that includes Klebsiella, Staphylococcus aureus, Mycobacterium tuberculosis, Pseudomonas aeruginosa, pertussis, and as well as the influenza virus. So these are the common organisms that will be causing bronchiectasis. So to summarize the things, what is the best initial test? The best initial test will be the HRCT. And in case of bronchiectasis, you also should be aware of which particular lobe is commonly affected. In case of bronchiectasis, the commonly affected lobe will be the left lower lobe. Right, the commonly affected lobe will be the left lower lobe. Now, after the involvement of the left lower lobe, the next lobe which is affected is the right middle lobe is being affected. And what about the involvement of the upper lobe? The upper lobe involvement in case of bronchiectasis, it is less frequent. Okay, so that is about the lobar description. And the special syndromes which are associated with the bronchiectasis, one already I have said you, that is Carter-Jenner syndrome, where you have rhinosinusitis, infertility, then bronchiectasis and situs inversus, and the other one is the middle lobe syndrome, right? Usually, like the middle lobe syndrome, it is uncommon. If there is middle lobe involvement for the development of the bronchiectasis, that we call it as the Brooks syndrome. Okay, yeah, so middle lobe syndrome, it is nothing but Brooks syndrome. And what are the various etiologies that will be causing the upper lobe bronchiectasis? That includes post-tubercular bronchiectasis, then followed by that cystic fibrosis, allergic bronchopulmonary aspergillosis, and then the radiation fibrosis. So these are the etiologies that will be causing upper lobe bronchiectasis. Then the middle lobe, as just now I was discussing, that is the Brooks syndrome. And what are the etiologies that will be causing lower lobe bronchiectasis? So please remember, it is mainly the aspiration, recurrent infections, and the childhood pneumonia. Aspiration, recurrent infections, and the childhood pneumonia. So these are the scenarios where you have the lower lobe involvement. So we classify the bronchiectasis into upper lobe, middle, and as well as the lower lobe bronchiectasis. So this is about one of the very important obstructive lung disease, that is bronchiectasis, right? Now, followed by this, another important obstructive lung disease, it is the cystic fibrosis. Now, cystic fibrosis, it is mainly due to gene mutation. And what is that particular gene that is being mutated? The gene that is being mutated is the CFTR gene is being mutated. And where exactly is this CFTR gene present? The CFTR gene, it is present on the chromosome number 7. Right, the CFTR gene, it is present on the chromosome number 7. And the most common mutation, it is F508 mutation. Right, where there is deletion of the phenylalanine on 508 position, and the CFTR gene that is being mutated, it is being inherited. How is it being inherited? The mode of inheritance is the autosomal recessive type of inheritance, right? And this CFTR gene, this will code for a protein. What is that protein? That is CFTR protein. Now, once this particular CFTR protein is being defective, what exactly will be the problem? Whatever the secretions which are being produced within the airway, the secretions, they become very thick, right? The secretions, they become very thick, and multiple organ involvement will be there in patients with the bronchiectasis. So please remember, it is not just only the lung involvement that you observe in patients with the bronchiectasis, even involvement of the GIT, pancreas, liver, and reproductive system. So these are all the organs which are affected in cystic fibrosis, but the most common among that is the lung involvement. And what is the pathogenesis? So because of the defective CFTR protein, what happens is there is defective chloride and as well as the water transport. There is defective chloride and as well as the water transport. Now once there is defective chloride and as well as water transport, that will make the mucus very thick. So you will notice that there is thickened mucus, and that is because of low water content and as well as the acidic environment. Now the point here that you need to understand is, whenever there is low water content and whenever you have the thick mucus, what will happen to the ciliary motility within the respiratory airway? There is impaired mucociliary clearance. There is impaired mucociliary clearance, and that will lead to biofilm formation, right? So because there is impaired mucociliary clearance, the organisms are not washed out. When the organisms are not being washed out, over that particular thick mucus, you have the formation of a biofilm, and that particular biofilm contains the Pseudomonas, Staphylococcus aureus, and as well as the Burkholderia. These are the organisms that will be there within this particular biofilm. Now, what will be that effect within the lung? Right? Within the lung, the problem that can happen is there will be development of the recurrent infections causing pneumonia. There can be formation of the lung abscess. There can be development of the bronchiectasis, right? And because of the hypoxemia caused by the lung parenchymal pathology, the individual will have hypoxia. Once there is hypoxia, that will cause pulmonary artery constriction, and that will increase the afterload on the right ventricle, and that will result in the development of the cor pulmonale. Then followed by that, the pneumothorax is another important complication, massive hemoptysis, and as well as the nasal polyps, right? Massive hemoptysis and as well as the nasal polyps. So these are the abnormalities observed in the lung. Then followed by that, gastrointestinal abnormalities. The gastrointestinal abnormalities that you observe in these patients is in the form of the meconium ileus. That will be in the form of the meconium ileus. So the presentation in children with cystic fibrosis, that will be in the form of meconium ileus, for which you need to give the gastrographin enema. And these patients, they will also have the malabsorption, and that malabsorption will lead to the development of steatorrhea and as well as the diarrhea. That will lead to the development of the steatorrhea and as well as the diarrhea. And these patients, because of the malabsorption, the growth is impaired, and that will result in the failure to thrive. And the other important gastrointestinal abnormalities will be in the form of the biliary cirrhosis and as well as the liver damage. So these are the gastrointestinal problems that observed in patients with cystic fibrosis. Then followed by that, what will be the pancreatic involvement? So there is exocrine pancreatic insufficiency. Thereby, the enzymes which are required for digestion of the carbohydrates, the enzymes which are required for digestion of lipids, the enzymes which are required for digestion of the proteins are deficient. So because of the exocrine deficiency, there will be malabsorption. And endocrine involvement can also be there, and that will result in the development of diabetes mellitus, but that will happen in the later stages. Then what will be the hepatic involvement, or what will be the hepatic abnormality? The hepatic abnormality that you see in patients with cystic fibrosis is that there is all the secretions, they are becoming very thick. So these patients, they will have the biliary stasis. Okay, because the biliary secretions also, they become thick, that will result in the biliary stasis. Now once there is biliary stasis, the movement of the bile into the second part of the duodenum does not occur, and that will result in the development of the obstructive jaundice, and there will also be secondary biliary cirrhosis, and there will also be liver dysfunction. So these will be the liver abnormality that you come across in patients with cystic fibrosis. So biliary stasis, secondary biliary cirrhosis, and then liver dysfunction. Then how is that you will be able to diagnose this cystic fibrosis? So you need to do a screening test, and that particular screening test is the sweat chloride test. So when you do a sweat chloride test, the sweat chloride will show you that there is more than 60 milliequivalents per liter. That is what is observed on two separate tests. That is what is being observed on two separate tests. That is what is the sweat chloride test. The next is the DNA testing. So the DNA testing will detect the presence of the CFTR mutation. Right, the DNA testing will detect the presence of the CFTR mutation. Now the investigation of choice, that will be the DNA testing. Now if this sweat chloride test is being equivocal, then in such case the test that you need to do is the nasal potential difference, which will show you that there is abnormal ion transport. And there is pancreatic insufficiency, both exocrine and as well as endocrine insufficiency. So how is that you will be able to tell that there is both exocrine and endocrine insufficiency of the pancreas is you need to do a fecal elastase test. So the fecal elastase test will detect the presence of the pancreatic insufficiency, right? Then what are the complications that you come across in patients with cystic fibrosis? Because there is recurrent infections, because the mucus secretions have become very thick, this particular mucus secretions will be acting as the seat for the source of infection, and these individuals will develop recurrent infection. Followed by that, there will be development of pneumothorax. There can be massive hemoptysis, 𝐸𝐴, and the another important complication is pancreatic insufficiency will result in the development of diabetes mellitus, and there will be liver cirrhosis and as well as the infertility. So these are the complications that you come across in patients with the cystic fibrosis. Then how do you treat these patients? See, what is our primary problem? The primary problem is the secretions have become very thick. Now these secretions have to be liquefied. So how is that you will liquefy the secretions? By giving the recombinant DNase, that is 𝐷𝐴 alpha, right? See, these particular 𝐷𝐴 alpha and as well as the inhalation of the hypertonic saline, that is 7% sodium chloride, these are the substances which will cause liquefaction of the sputum. Then you need to do the upregulation or the trafficking of the CFTR, because CFTR gene is being defective, and because of which the CFTR protein is being defective. And because of these two problems, like in order to ensure that the CFTR is being corrected, you need to give CFTR tracking agents. That includes the 𝐒𝐼𝐜𝐴. So 𝐒𝐼𝐜𝐴 should be given for G551D mutation. Then followed by that, you need to give 𝗟𝐴𝐵𝐾, 𝗏𝑍𝐴𝐵𝐾, and as well as the 𝐒𝐼𝐜𝐴. So these are the drugs which are given in order to improve the efficacy of the CFTR. Now these patients, they are at a risk of recurrent infections, for which you need to give the antibiotics. So the antibiotics are tailored mainly to treat the infections like Pseudomonas, because this is the most common organism which is causing pneumonia in patients with the cystic fibrosis. Now when the individual is having the lung pathology in diffuse bilateral in cystic fibrosis, then the definitive treatment in advanced cases will be the lung transplantation. Now because these individuals are more prone for recurrent infections due to thick mucus, these patients will be requiring vaccination, and the vaccination that you need to give is the pneumococcal and as well as the annual influenza vaccine is being recommended. And what is the prognosis in these individuals? The median survival of these individuals is like more than 39 years, and most deaths, they occur due to pulmonary complications or the chronic respiratory failure. Due to pulmonary complications or chronic respiratory failure. So this is how the prognosis in these patients with the cystic fibrosis will be. So cystic fibrosis, it's an obstructive lung disease where you have CFTR gene that is being mutated, and this particular CFTR gene is present on chromosome number 7, and the type of mutation will be the deletion of phenylalanine on the amino acid number 508, right? And it is a multi-system involvement where you have the involvement of the lungs, GAT, pancreas, liver, and as well as reproductive system, right? Now, having discussed about the cystic fibrosis, the next important topic for the discussion will be bronchogenic carcinoma. So, if you take this bronchogenic carcinoma, it is a malignant neoplasm which is originating from the epithelium of the bronchus and as well as the bronchiole, right? And so it's a malignant neoplasm from epithelium of the bronchus and as well as the bronchiole. Now what are the types of the bronchogenic carcinoma? The types of the bronchogenic carcinoma, that includes the squamous cell carcinoma, adenocarcinoma, small cell, and as well as the large cell carcinoma. In India, the most common cause for bronchogenic carcinoma will be squamous cell carcinoma, whereas all over the world, the most common cause for bronchogenic carcinoma will be the adenocarcinoma. Then what are the risk factors for the development of the bronchogenic carcinoma? The most common risk factor for the development of bronchogenic carcinoma is the cigarette smoking, right? And next to the cigarette smoking, if you take the environmental risk factors, the environmental risk factors include the exposure to the radon gas, right? Exposure to the radon gas is another important risk factor for the development of bronchogenic carcinoma. Then followed by that, the asbestos, metals like arsenic, chromium, and as well as nickel, and the industrial carcinogens. These are the risk factors for the development of the bronchogenic carcinoma. Then what are the histological types for the bronchogenic carcinoma? As I have said you, adenocarcinoma is the most common type of bronchogenic carcinoma, and this adenocarcinoma, it is more commonly observed in women, right? It is more commonly observed in women rather than men, and it is in the peripheral location, right? It is the peripherally located, and this adenocarcinoma, it is commonly observed in non-smokers, common in women, non-smokers, and peripheral location. Then you take the squamous cell carcinoma. Squamous cell carcinoma, it is associated with smoking, and it is a central tumor, right? And it is a central tumor. Then followed by that, we have small cell lung cancer. Small cell lung cancer, it is the most aggressive cancer, and it is the one which has worse prognosis, and it is observed in smokers, and it is also the one which is a central tumor. Whereas large cell carcinoma is poorly differentiated tumor, and it is the peripheral tumor, right? It is both actually peripheral more than compared to that of the central. Now, if you take the symptoms in case of the central tumors, they are mainly because of the obstruction on the bronchus and as well as the alveoli. Accordingly, these patients will have cough, dyspnea, hemoptysis, wheezing, pneumonia due to airway obstruction. Whereas you take in adenocarcinoma, which is a peripheral carcinoma, large cell carcinoma, which is a peripheral carcinoma, there can be spread of the tumor to the pleura, resulting in pleuritis, so there will be chest pain. And at the same time, because the peripheral component of the lung gets affected, there will be restriction of the expansion of the lung, and that can contribute to the development of dyspnea. Now, if you take some special syndromes with the bronchogenic carcinoma, some of the special syndromes are the Pancoast syndrome. So if you take this Pancoast syndrome, it is commonly observed in patients with the adenocarcinoma. So in case of the adenocarcinoma, the tumor which is growing at the apex, that can cause the compression of the cervical sympathetic chains, and that will result in the development of the Horner syndrome. Then there can be erosion of the first rib, and there will also be shoulder pain. So these are the features that you observe in case of the Pancoast syndrome. And not only that, in case of the small cell cancer, right, in case of the small cell cancer, the tumor can compress the superior vena cava, thereby the venous drainage from the face and as well as the upper limbs are completely compromised. That will result in the development of the superior vena cava syndrome. So that will cause the swelling of the face, neck, arms, and there will be dilated chest veins, and there is also association with small cell lung carcinoma. So these are the two important syndromes. One is Pancoast syndrome, the other one is the superior vena cava syndrome. And if you take this paraneoplastic syndromes associated with the bronchogenic carcinoma, so if you take this small cell lung cancer, it acts as an ectopic source for the production of the ACTH that will result in Cushing's. This small cell lung cancer will be acting as the source for the ADH that will result in the syndrome of inappropriate antidiuretic hormone. And in small cell lung cancer, the antibodies are formed against the calcium channels which are present on the presynaptic nerve terminals, and that will result in the Lambert-Eaton myasthenic syndrome, right? And not only that, this small cell lung cancer will be also acting as the source for the production of the atrial natriuretic peptide. Then you take the squamous cell carcinoma. Squamous cell carcinoma, if you observe, that will be acting as a source for parathormone related protein, and the parathormone which is being produced, that will result in the hypercalcemia, right? So these are the two important paraneoplastic syndromes that you need to be aware of. One is small cell lung cancer and the other one is squamous cell lung cancer. Next, coming to the diagnosis. So the first line investigation is the chest x-ray. What the chest x-ray will show you? The chest x-ray will show you that there is presence of the opacity. But the HRCT will tell you what is the size of the tumor and as well as the extension of the tumor. That is what you will be able to make out on the imaging. Then if you take the sputum cytology, so sputum cytology, you require almost more than 5 sputum samples that has to be examined. So when you examine more than 5 samples, the sensitivity of it to detect the malignant cells is nearly around 69% is the sensitivity. Then what exactly is the investigation of choice? The investigation of choice will be the biopsy. So when you do a biopsy, of the central tumor, you will be able to visualize the malignant cells. The next one is the transthoracic needle aspiration has to be done for the peripheral tumors. So this is about the diagnosis. So the diagnosis or the investigation of choice is bronchoscopy plus biopsy. That is how you need to do the diagnosis. That is the investigation of choice. Next, if you see the treatment in patients with the bronchogenic carcinoma, so we have small cell and we have non-small cell lung cancer. So in case of small cell lung cancer, because it's an aggressive tumor, there is high chances of metastasis to the distant organs. So these patients require the chemotherapy. Surgical resection will not be good or will not be efficient in case of small cell lung cancer. The chemotherapy include the etoposide. Along with etoposide, you need to give either cisplatin or the carboplatin. And as I have said you, because it is highly aggressive tumor where it can spread, the surgery, it is ineffective in cases of the small cell lung cancer. Then you take the non-small cell lung cancer, the surgical resection has to be done if the tumor is localized. And if the tumor has spread to the distant organs, then you need to give chemotherapy, and that chemotherapy include the paclitaxel and as well as the carboplatin. Along with that, you also need to give the radiation. So this is what is the treatment for the small cell and as well as the non-small cell lung cancer. Then what is the complications which are associated with this bronchogenic carcinoma? That is the invasion. So there can be local invasion and there can be distant metastasis also. So if you take the local invasion can be to the pleural space resulting in pleural effusion. There can be compression of the superior vena cava resulting in SVC syndrome, and there can be a rupture of the blood vessels resulting in hemoptysis. So these are the local invasion complications. Then coming to the distant metastasis. Distant metastasis, if you observe, it can metastasize to the liver, it can metastasize to the brain, it can metastasize to the adrenal gland. So this will be the distant metastatic abnormalities. Then coming to the paraneoplastic syndromes. Paraneoplastic syndromes, as I have said you, small cell lung cancer, it is associated with ACTH secretion, SIADH and Lambert-Eaton myasthenic syndrome. Then another important paraneoplastic will be the squamous cell, which is releasing the parathormone related protein that will release parathormone that will cause the hypercalcemia. So these two are the paraneoplastic syndromes. Then how will be the prognosis in these patients? So prognosis in these individuals will be like you take the small cell lung cancer, the prognosis is very bad. So these patients, they will have the poor prognosis, and that is mainly because of the metastasis and as well as the aggressive nature of the disease. Then you take non-small cell lung cancer. Non-small cell lung cancer, they have good prognosis, right? They have better prognosis with early detection and as well as the surgical resection. So that is what is for the non-small cell lung cancer. So non-small cell lung cancer like adenocarcinoma, squamous cell carcinoma, they have good prognosis. But small cell carcinomas, they are having excessive chances of metastasis. The prognosis is very bad. So this is about the bronchogenic carcinoma. So it's a malignant neoplasm which is originating from the epithelium of the bronchus and as well as bronchiole. And cigarette smoking, it's the most common risk factor, and squamous cell carcinoma is the most common bronchogenic carcinoma in India, and adenocarcinoma most common all over the world. And the clinical features completely depends upon whether the tumor is central or whether the tumor is peripheral. The special syndromes are the Pancoast syndrome and superior vena cava syndrome. And the paraneoplastic syndromes, if you observe the small cell carcinoma, small cell lung cancer, there is excessive ACTH secretion, there is excessive ADH production, and there is also development of Lambert-Eaton myasthenic syndrome. And small cell lung cancer, if you take squamous cell, it is associated with the release of parathormone, and that will cause hypercalcemia. And the investigation of choice is you need to do bronchoscopy and then biopsy. And small cell lung cancer will be requiring chemotherapy, and non-small cell lung cancer, if it is localized, you need to do surgical resection, right? So this is about the bronchogenic carcinoma. Then followed by the bronchogenic carcinoma, the next important topic for the discussion is the pulmonary embolism. So in pulmonary embolism, you have the presence of the large embolus within the pulmonary artery, and that is causing the obstruction to the flow within the pulmonary artery, right? So obstruction of the pulmonary artery or its branches by thrombus, air, fat or amniotic fluid. And this pulmonary embolism, it is most commonly caused by thrombus from the lower extremities. right? Most commonly caused by thrombus from the lower extremities, right? Then what are the risk factors for the development of the pulmonary embolism? We have acquired and as well as the inherited risk factors. The acquired risk factors include like surgery, trauma, immobilization, pregnancy, oral contraceptive pills which are rich in the estrogen, right? Oral contraceptive pills which are rich in the estrogen. And the other important etiology will be malignancy. So these are the acquired causes. Then if you take the inherited causes, we have factor V Leiden mutation, protein C proteinase deficiency, and as well as the antithrombin 3 deficiency. So these are the inherited causes for the development of the pulmonary embolism or the hypercoagulability. And if you take the clinical features in these patients, the symptoms that you commonly observe in these patients will be sudden onset dyspnea, right? So sudden onset dyspnea, that is the most common finding. Then followed by that, these patients will have chest pain, and that too, it is like pleuritic. Or why is this chest pain? This is due to pulmonary infarction, or it could be because of the pleuritis. These patients will be having chest pain. And this infarcted lung parenchyma can irritate the airway, that can result in the cough. And the other features are hemoptysis. And why they will be having syncopal attack is that is mainly observed in patients with massive pulmonary embolism. In massive pulmonary embolism, there is increased afterload on the right ventricle, and there is increased pressure within the right ventricle, and that will push the interventricular septum to the LV. So the LV volume reduces and the cardiac output is reduced, and once the cardiac output is reduced, the cerebral perfusion reduces, and that will result in the development of the syncopal attack, right? Now coming to the signs that you come across in these individuals. So these patients will have tachypnea, that is the most common sign, right? Tachypnea, that will be the most common sign. And the other features that you come across is tachypnea and tachycardia, and there will also be elevated JVP, and because of pulmonary arterial hypertension there will be loud P2, and there is right heart strain pattern on the ECG. There is right heart strain pattern on the ECG. So this will be the signs and symptoms in patients with the pulmonary embolism. Then if you take the types of pulmonary embolism, in cases of massive pulmonary embolism, these patients will have right ventricular dysfunction and as well as hypotension, and that requires thrombolysis. Then submassive pulmonary embolism, there will be right ventricular dysfunction with normal blood pressure, and they don't require thrombolysis, except for young individuals they may be requiring thrombolysis. And in low risk pulmonary embolism, there is no RV strain and there is normal hemodynamics, and these patients they require heparin. So that is what you observe in case of low risk pulmonary embolism. Then if you take the diagnostic test, the initial test will be D-dimer. So D-dimer, it is a screening test, but that is not specific, it is only sensitive. And what is the definitive test? The definitive test will be the CT pulmonary angiography, right? And then what is the second best investigation? The second best investigation will be the ventilation perfusion scan, and these patients require the Doppler ultrasound for deep vein thrombosis. So this is about the workup. So D-dimer, CT pulmonary angiography, then Doppler ultrasound and VP scan. ECG finding, if you observe, what is the most common ECG finding? The most common ECG finding that you will observe in these patients will be sinus tachycardia will be the most common ECG finding. Next to this sinus tachycardia, these patients will have the features of the right ventricular strain pattern. What will be the features of the right ventricular strain pattern? That includes the RBBB, right axis deviation, T-wave inversion, and in the right sided leads. And in cases of the massive pulmonary embolism, these patients will have the S1Q3T3 pattern that is observed in case of massive pulmonary embolism. Then when you do a chest X-ray in these patients, because of the presence of the pulmonary embolism, there can be a wedge-shaped infarct, and this particular wedge-shaped infarct is the Hampton's hump. And there can also be focal oligemia, and this focal oligemia, it is nothing but the Western mark sign. And because of the pulmonary arterial hypertension, there is enlarged descending pulmonary artery, and that is what is nothing but the Pallas sign. So Hampton's hump, Western mark sign, and as well as the Pallas sign. So these are the chest X-ray finding. Then how do you treat these patients? So the treatment is, if there is massive pulmonary embolism causing right ventricular dysfunction and hypotension, these require the thrombolysis. And thrombolysis should be given with the help of the altiplase. And in refractory cases, you need to plan for the embolectomy. Whereas in case of the submassive pulmonary embolism, the anticoagulants, that is low molecular weight heparin or fondaparinux, should be given during the time of the hospital admission, and at the time of discharge you need to give newer oral anticoagulants. But if the patient is having recurrent pulmonary embolism and if the source is from the lower limb, then in such case scenarios you need to place the IVC filters. So the IVC filter is indicated in case of recurrent pulmonary embolism, or in case of those individuals who are having the bleeding risk in them, you need to place the IVC filters. Then what are the complications of the pulmonary embolism? The complications of pulmonary embolism: pulmonary infarction, right ventricular failure, and there can also be development of chronic thromboembolic pulmonary hypertension. So this will be the complications that you observe in patients with pulmonary embolism. Then how is the prognosis in these patients? In cases of massive pulmonary embolism, the mortality is high. In case of massive pulmonary embolism, the mortality is high. Whereas in those individuals with submassive pulmonary embolism or low risk pulmonary embolism, the outcome is good. So this is what is your pulmonary embolism. So, and one more important thing that you need to know is the criteria. So we have a criteria called the Wells criteria for diagnosing pulmonary embolism, and within the Wells criteria, if the score is more than 6, that is suggestive that the individual is having pulmonary embolism, right? So this is about the pulmonary embolism. So most common symptomatology will be dyspnea, right? And most common sign will be tachypnea, and P2 will be loud. And these patients, the complication that can occur is development of the cor pulmonale, right? And the clinical features completely depends upon the severity of the pulmonary embolism. In massive pulmonary embolism, you will have the right ventricular dysfunction and hypotension, and the risk factors that includes acquired and as well as the inherited risk factors. And diagnostic test, if you include, or if you see the diagnostic test, the investigation of choice will be CT pulmonary angiography, right? And the second line investigation will be ventilation perfusion scan. The ECG finding include, the most common ECG finding will include the sinus tachycardia, and the chest X-ray shows the Hampton sump, then Pallas sign, then the Western mark sign. And the treatment is, in massive pulmonary embolism you need to do a thrombolysis, and submassive pulmonary embolism you need to give heparin or low molecular weight heparin should be given. And in recurrent pulmonary embolism you need to place the IVC filters, right? Then followed by that, fat embolism syndrome. Fat embolism syndrome, this is basically an inflammatory response to the fat droplets. Okay, so the systemic inflammatory response which is caused by the presence of the fat droplets in the circulation, that is what is the fat embolism syndrome. And this typically occurs after the trauma or the orthopedic surgery. What is the common cause for fat embolism syndrome? The common cause for fat embolism syndrome include the polytrauma, that is the fracture of the long bones, fracture of the pelvis, and the incidence of polytrauma causing fat embolism syndrome, it is almost 90%. And the other etiologies are the acute pancreatitis, hypertriglyceridemia, mainly when the triglyceride levels are more than 500 milligrams percentage. These patients, they are at risk of development of the fat embolism syndrome. Joint reconstruction surgery, liposuction, and as well as the intravenous fat infusion. So these are the causes for the development of the fat embolism syndrome. Now if you take the pathogenesis, so from the fat you have the release of the free fatty acids, and these free fatty acids will cause damage to the capillary endothelium, right? And these particular fat emboli can also enter into this central nervous system or into the cerebral circulation, that is via patent foramen ovale. And this particular fat embolism syndrome, it causes cognitive defects, coma, and as well as the hypoxia. So this will be the pathogenesis. And what is the name of the criteria in case of the fat embolism syndrome? The name of the criteria is the GERD and the Wilson's criteria. So in this you have the major and as well as you have the minor criteria. What is the major criteria? The major criteria will be respiratory distress, CNS involvement, that will be there in the form of coma, and there will be like petechiae. And this petechiae, they are commonly observed in the axilla then compared to that of the body. This will be the major criteria. Then minor criteria, if you observe, there is like tachycardia, fever, retinal changes, jaundice, anemia, thrombocytopenia, and the presence of fat in the urine or the sputum. So this will be the minor criteria. So major criteria is respiratory distress. In minor criteria is tachycardia, fever, retinal changes, jaundice, anemia, thrombocytopenia, and the presence of the fat in the urine or the sputum. Coming to the diagnosis. The chest X-ray is the one by which you can diagnose, and what the chest X-ray shows you, either it may be normal or it can be presence of diffuse infiltrates if it is like massive fat embolism syndrome. CT will show you GGO, that is ground glass opacities, and when you take the CT of the head, that will show you the presence of the white matter petechiae, and transesophageal echo will demonstrate the presence of patent foramen ovale. Patent foramen ovale is the source for the cerebral circulation of this fat emboli. And bronchoalveolar lavage, you need to stain for the fat, right? You need to stain for fat. And how do you treat this fat embolism syndrome? So you need to give the high flow oxygen that will be at a range of 12 liters per minute. The IV fluids have to be given for the hydration. Steroids have to be given for the cerebral edema. And heparin should be given for the anti-lipemic effect. Compression stockings, that is mainly to prevent the deep vein thrombosis, and proton pump inhibitors, that is mainly to prevent the gastrointestinal stress ulcers. So this will be the management in case of the fat embolism syndrome. And the complications include respiratory failure, multi-organ dysfunction, cerebral edema, and as well as the death of the individual. So this will be the features of the fat embolism syndrome. So it's a systemic inflammatory response to the presence of the droplets of the fat which is present in the circulation. Polytrauma is the most common cause, and it is mainly the free fatty acids which are released into the circulation that will damage the capillary endothelium, and there is also CNS involvement. The name of the criteria is GERD and Wilson's criteria. Major criteria you have respiratory distress, and minor criteria you will have tachypnea, tachycardia, fever, retinal changes. So the diagnosis is mainly by CT chest and CT of the head, and transesophageal echocardiography will show you the presence of patent foramen ovale, and bronchoalveolar lavage will show you the presence of the staining of the fat. Management, you need to give high flow oxygen, and steroids have to be given for cerebral edema. Heparin should be given for anti-lipemic effect. Compression stockings to prevent the deep vein thrombosis. And the complications include respiratory failure and the multi-organ dysfunction, right? Now, so the next topic in the respiratory system is the respiratory failure. So in the respiratory failure, we have totally 4 types, type 1, 2, 3, and as well as 4. So if you take this respiratory failure, what exactly is the problem? So it is a clinical condition where the lungs are unable to meet the body's metabolic demands, right? Because there is hypoxia and there can be hypercapnia in certain types of the respiratory failure. So we have totally 4 types, type 1, 2, 3 and 4. So type 1, it is hypoxemic respiratory failure, and this type 1, it is due to alveolar hypoventilation, right? It is due to alveolar hypoventilation. And because of this alveolar hypoventilation, in case of type 1 respiratory failure, there will be hypoxia. And next is the carbon dioxide. Carbon dioxide levels, they may be normal or they may be decreased also in case of type 1 respiratory failure. And the etiology, I will discuss that in detail, but one of the important etiology is ARDS, that to mild to moderate form of ARDS and pneumonia. Whereas type 2 respiratory failure, it is hypercapnic respiratory failure, where in case of type 2, there will be hypoxia and there will be hypercapnia, right? And a small correction here, okay, a small correction. So type 1 respiratory failure, it is mainly due to alveolar flooding. I'm very sorry for this. Whereas you take type 2 respiratory failure. So type 2 respiratory failure, this is due to alveolar hypoventilation. And in type 2 respiratory failure, you will have hypoxia and as well as the hypercapnia. Then coming to type 3 respiratory failure, which is also called perioperative respiratory failure. And this, there is usually the collapse of the lung or atelectasis of the lung. And these patients will also have the hypoxia and as well as hypercapnia. But the etiology is perioperative respiratory failure, right? Perioperative state, there should be recovery of the skeletal muscles of the respiratory system, and there should be recovery of the lungs which has been collapsed due to skeletal muscle relaxants which has been given during the surgery. But in type 3, there is perioperative respiratory failure. The respiratory muscles, they will not be able to recover their strength and the lung will be in a collapsed state. So there will be atelectasis. Whereas type 4 respiratory failure, so normally if you take respiratory muscles, they consume less than 5% of the oxygen, right? They consume less than 5% of the cardiac output. So in case of type 4 respiratory failure, it is secondary to cardiogenic shock. And because of the cardiogenic shock, right, because of the cardiogenic shock, there is hypoperfusion of the respiratory muscles, and because of the hypoperfusion of the respiratory muscles, these patients, they will land up in respiratory failure. So there will be hypoxia and as well as the hypercapnia. Now if you take the causes of the respiratory failure of various types, so type 1 respiratory failure, I have already said you, it is due to alveolar flooding, and in patients with ARDS there will be non-cardiogenic pulmonary edema, and that too in case of mild to moderate form of ARDS you will have type 1 respiratory failure, whereas in severe form of the ARDS, right, whereas in severe form of ARDS it will be type 2 respiratory failure. So in type 1 is observed in ARDS, pulmonary embolism, pneumonia, and as well as the pulmonary edema. So in all these scenarios there is like alveolar flooding. Then you take type 2 respiratory failure, which is due to the alveolar hypoventilation, where there is respiratory muscle paralysis, and this occurs mainly because of the chronic bronchitis, the obstructive sleep apnea, myasthenia gravis, Guillain-Barré syndrome, and the severe asthma. That is your type 2 respiratory failure. So type 2 respiratory failure is due to alveolar hypoventilation. And next important is the severe form of ARDS. And apart from this, we also have certain drugs, that is morphine. So morphine, it is the opioids which will cause the respiratory center depression. And the other thing is the brainstem injury secondary to head trauma. Or the other important etiologies will be hypothyroidism, right? The other important etiologies will be hypothyroidism. These are the causes for the type 2 respiratory failure. Then coming to type 3 respiratory failure, as already I have said you, it is perioperative respiratory failure, that is due to lung atelectasis. And the etiology for type 3 will be obesity, anesthesia, and then the abdominal surgery. And type 4, as already I have said you, due to cardiogenic shock, where the respiratory muscle perfusion will be reduced. And this cardiogenic shock, it could be due to the coronary artery disease, or it could be secondary to your cardiomyopathies also. And even in cases of sepsis, the respiratory muscle perfusion will be reduced, and that also constitutes type 4 respiratory failure. So this is about the types of respiratory failure, type 1, 2, 3 and 4. Then coming to the clinical features, in all these individuals, the common clinical feature will be dyspnea, and that is because of the hypoxia. Whereas you take in case of type 2 respiratory failure, there is hypercapnia. Because of the hypercapnia, these patients will have the central nervous system manifestations, and that central nervous system manifestations will be in the form of headache, drowsiness, and as well as the confusion. So this headache, drowsiness, and as well as confusion, it mainly observed wherever there is hypercapnia, and that is commonly observed in case of type 2 respiratory failure. Whereas in type 3 respiratory failure, there is the postoperative hypoxemia, and then there is also atelectasis. Whereas type 4 respiratory failure, there is respiratory muscle fatigue, and there will also be lactic acidosis. And why is that due to? That is due to cardiogenic shock and decreased respiratory muscle perfusion. So this will be the clinical features. And how will you work up these patients with the respiratory failure? When you do an ABG, ABG will show you that type 1 respiratory failure, there is hypoxia and carbon dioxide levels, they remain normal or reduced. Whereas you take in case of the type 2 respiratory failure, in case of the type 2 respiratory failure, these patients, they will have hypoxia and they will also have the hypercapnia in case of type 2 respiratory failure. Then coming to the imaging. So imaging like chest x-ray, CT scan, that will help in identifying what is the underlying cause for the development of the respiratory failure. Next is polysomnography. Polysomnography will help us in making out what is the cause. Like for example, obstructive sleep apnea, that is one of the cause for respiratory failure. So for diagnosing obstructive sleep apnea, you need to do this polysomnography. So this is about the diagnostic test. Now coming to the treatment. See, in all of these types of respiratory failure, the common thing is hypoxia. So in all of these patients, they will require oxygen therapy. And if the individual is refractory to oxygen therapy by the oxygen mask, then these patients have to be intubated and placed on mechanical ventilator. And upon all, you also need to treat whatever is the underlying cause for the development of the respiratory failure. So similarly, in type 2 respiratory failure, the individual has to be placed on the non-invasive ventilator first. That is either your CPAP and as well as BiPAP. And what is the target in case of type 2 respiratory failure? Even the carbon dioxide washout also have to be achieved. And if the individual does not respond to your non-invasive ventilator, then you need to place the individual on the endotracheal tube. Then type 3 respiratory failure, it is perioperative respiratory failure where there is lung atelectasis, and that is due to respiratory muscle paralysis. So in case of type 3 respiratory failure, chest physiotherapy, right? So in type 3 respiratory failure, chest physiotherapy is very, very important. Why is that you need to do a chest physiotherapy? In order to improve the strength of the respiratory muscles, you need to do chest physiotherapy. Then coming to the type 4 respiratory failure, and it is due to cardiogenic shock. So what is that you need to start with? You need to start with the inotropes, and you need to place the individual on the mechanical ventilator. So when you place the individual on inotropes, and once you place the individual on mechanical ventilator, what this will do? This will improve the cardiac output and it will improve the respiratory muscle perfusion. So that will be your type 4 respiratory failure. Now coming to the complications associated with the respiratory failure, that includes pulmonary hypertension. And what could be the reason for pulmonary hypertension? That is hypoxia. So whenever there is hypoxia, that will cause pulmonary artery vasoconstriction, and that will result in the pulmonary hypertension. Next is core pulmonary. Once there is pulmonary hypertension, what will happen to the afterload on the right ventricle? The afterload on the right ventricle increases, and that will result in what is called the core pulmonary. Next is hypoxic brain injury, and that is due to decreased oxygen perfusion. And there will also be multi-organ failure. So these all will be the features that you will have in patients with the these are all the complications in patients with the respiratory failure. So we have totally 4 types. Type 1, alveolar flooding, hypoxia, carbon dioxide levels normal or reduced. Type 2, due to alveolar hypoventilation, there will be hypoxia and hypercapnia. And type 3, perioperative respiratory failure, and there is lung atelectasis. Type 4, due to cardiogenic shock, right? Next, followed by that, let me discuss about the pneumonias. Now what exactly is the pneumonia? So pneumonia, it is the infection within the lung, right? It is the infection within the lung, and this particular infection, it especially affects the alveoli, and because of this infection, these patients will have fever, chest symptoms, and consolidation which is visible on the chest x-ray. So this will be the definition of the pneumonia. Now if you take the classification of the pneumonia, so we have anatomical classification of pneumonia, and second important thing is from where the organism is acquired, right? From where the organism is acquired. So you take anatomical classification, you have like lobar pneumonia where the entire lobe of the lung is being consolidated, right? So either it might be the upper lobes or the lower lobes, but the most common organism that will be causing lobar pneumonia will be Streptococcus pneumonia, which is nothing but the pneumococci. And this Streptococcus pneumonia, preferably it involves the lower lobes. And another important organism that will be causing lobar pneumonia will be Klebsiella. And Klebsiella, the infection is mainly confined to the posterior segment of the right upper lobe, and that is what is called the bulging fissure sign. Then followed by that, bronchopneumonia. Bronchopneumonia is that where it is not the lobar consolidation, you have the presence of the patchy consolidation, and the organism here will be the Staphylococcus aureus. That will be your bronchopneumonia. Then followed by that, the interstitial pneumonia. So in case of bronchopneumonia, it is not the lobe of the lung that is being consolidated, it is the patchy consolidation. Whereas you take the interstitial pneumonia. In case of interstitial pneumonia, the consolidation is not confined to the lobe, it is the infection and inflammation within the interstitium of the lung. That is what is called as the interstitial pneumonia. So this involves the interstitial tissue without airspace consolidation. And what are the organisms that will be causing this interstitial pneumonia? So this interstitial pneumonia This is also called as the atypical pneumonia, right? This is also called atypical pneumonia, and the organisms will be Mycoplasma, Legionella, and Chlamydia. These three are the important organisms that will be causing the interstitial pneumonia. And apart from this Mycoplasma, Legionella, and Chlamydia, we also have some viral infections that will contribute to the interstitial pneumonia. That includes the adenovirus, influenza virus, cytomegalovirus, the HIV, and even COVID-19. They contribute to the interstitial pneumonia. Then next important is from where the organism has been acquired, that is community acquired pneumonia. So the most common organism that will be causing community acquired pneumonia will be Streptococcus pneumonia. Then followed by that we have the other organisms like Haemophilus influenza, Mycoplasma, and the Legionella. Whereas you take nosocomial pneumonias, these are the one which occur when the individual enters the hospital premises. And this nosocomial pneumonias, again we have two types. One is the hospital acquired pneumonias, and the other one is the ventilator associated pneumonias. Hospital acquired pneumonias are that where the individual will develop pneumonia within 48 hours of admission into the hospital. That is called hospital acquired pneumonia. Whereas ventilator associated pneumonia is that the individual develops pneumonia after 48 to 72 hours of the endotracheal intubation. This is what is called the ventilator associated pneumonia. And what are the most common organisms that will be causing these nosocomial pneumonias are the Klebsiella, Pseudomonas, Staph, and as well as the Enterobacter species. So these will be the organisms that will be causing the nosocomial pneumonias. Now you should also be able to pick up the organism depending upon the color of the sputum as well. So where you take the rusty sputum. Rusty sputum is observed in case of the pneumococcal pneumonia, which is the most common organism that will be causing community acquired pneumonia or the lobar pneumonia. And red currant jelly, it is observed in Klebsiella pneumonia. And another name for the Klebsiella pneumonia, it is also called as the Friedlander's pneumonia. Right, it is also called as Friedlander's pneumonia, and the lobe which is mainly affected is the posterior segment of the right upper lobe, and that is what is called as the bulging fissure sign. Next is the green sputum. So you have the presence of the green sputum in case of the Pseudomonas and as well as the Haemophilus influenza. Then you have the yellow or thick sputum that is present in the bacterial infection. Next important is the frothy or the pink sputum. See, frothy or pink frothy sputum, it is not observed, right? It is not observed in case of any pneumonias. The pink frothy sputum, it is observed in cases of the pulmonary edema. So that is about the sputum color and as well as the etiology. Then coming to the risk factors. So now what are the risk factors that will contribute to the development of the pneumonia is mainly the immunocompromised status. That is the advanced age of the individual, like smoking, because smoking will reduce the ciliary motility within the airway and thereby the individual is more prone for the infectious organisms. Then chronic diseases, then followed by immunosuppression when the individual is like having HIV or when the individual is immunocompromised because of the intake of the steroids, the alcohol use, prolonged hospital stay, mechanical ventilation. These are all the risk factors for the development of the pneumonia. And the important clinical features will be what? Development of the fever. And along with fever, the individual will have cough with expectoration, and this particular expectoration will be of various colors, and depending upon the color you will be able to make out the organism. And next important is these patients will have dyspnea and as well as the chest pain. Now what could be the reason for the development of the chest pain? And that is due to pleuritis. So because of the pleuritis, these patients will develop the chest pain. And another important clinical manifestation is there will be cyanosis. And what could be the reason for the cyanosis? That is due to impairment of the gaseous exchange. And due to the accumulation of the fluid within the alveoli, where you have the inflammatory exudate within the alveoli, that will result in the development of the crackles. And the type of bronchial breath sounds that you will have here is the tubular type of the bronchial breath sounds. And these patients, as I have said you in case of pneumococcal pneumonia, it is rusty sputum, whereas Klebsiella, you have red currant jelly. And the very important point that you need to remember is on auscultation. So on auscultation, the vocal resonance is increased and there will be egophony, right? There will be egophony. So increased vocal resonance and as well as the egophony. These two are the important auscultatory findings in patients with pneumonia with lobar consolidation. Now, coming to the diagnosis. So if you take the diagnosis, what does the chest X-ray shows? The chest X-ray shows the presence of consolidation and as well as the air bronchograms. But these air bronchograms, they are present mainly in case of the lobar pneumonia, right? Air bronchograms, they are present mainly in case of the lobar pneumonia. And what does the chest x-ray shows in case of the Klebsiella pneumonia? That is also lobar pneumonia, where you have the presence of air bronchograms, that is in the right upper lobe. Whereas in case of the bronchopneumonia, which is caused by Staphylococcus aureus, you will have the patchy consolidation. You don't have the consolidation confined to one particular lobe. Whereas in case of the atypical pneumonia, which is also called interstitial pneumonia, the pattern that we describe it as the interstitial pattern. That is what is observed in case of Mycoplasma, Legionella, and as well as the Chlamydia. Then followed by that, you take the blood test. Blood test, you will notice that there is polymorphonuclear leukocytes, where there will be increase in the WBC count, and the blood culture and should be done, that is to make out the culture and sensitivity, where the organism will be picked up, and accordingly you can hit with the proper antibiotic to that organism. And sputum analysis also is very important, where you need to do a gram stain and as well as culture and sensitivity. And for certain organisms, you need to do the urinary antigen test, and that is mainly for the Legionella and as well as the Streptococcus pneumonia. Even the urinary antigen test of these organisms can also be positive. Next, coming to the treatment. So treatment, it completely depends upon what is the severity of the pneumonia. So how will you assess the severity of the pneumonia? You will be able to assess the severity of the pneumonia by the 𝐒𝐝65, right? Now what does this 𝐒𝐝65 stands for? Right? So the individual having confusion, give a score of 1 point. Urea more than 7 millimoles per liter, give a score of 1 point. Respiratory rate more than 30 per minute, give a score of 1 point. And the blood pressure of the individual less than 90/60, give a score of 1 point. Age of the individual more than 65 years, give a score of 1 point. Okay, so now after giving this particular scoring, you need to calculate the total score. So if the total score is like 0 to 1, you need to admit the patient, you need to treat the patient on OPD basis by giving oral antibiotics. And if if the score is 2, you need to give IV antibiotics and you need to admit the patient in the hospital. And if the score is like more than or equal to 3, you need to give IV antibiotics and you need to admit the patient in the ICU. So this is about the 𝐒𝐝65. So the treatment, if you see, definitely the antibiotics, they are the one which plays an important role in the treatment. And the antibiotics completely depends upon the culture and sensitivity, or you can also give the empirical antibiotics like penicillin for the pneumococcal pneumonia, macrolides for the atypical pneumonias. And apart from this, the antibiotic, even supportive therapy is also very, very important. So what is that supportive therapy? That is the oxygen therapy and as well as the IV fluids. And that particular IV fluids that we give is in the form of normal saline. But because of severe form of pneumonia, if the individual goes into a hypoglycemia, you need to give dextrose solution. Then what are the complications which are associated with pneumonia? See, this pneumonia can be confined to one particular lobe and there can be the abscess formation. And the pneumonia can also spread into the pleural space in the form of the pleural effusion. And if this pleural fluid is infected, that can result in the empyema. And followed by that, there can be development of a non-cardiogenic pulmonary edema, that is called ARDS. Actually, what is the most common direct lung injury causing ARDS? That will be pneumonia. So ARDS is one of the complications. Next is sepsis. And the infection can also spread to the different parts of the body. The infection can spread to the brain, resulting in the meningitis. The infection can spread to the heart, resulting in endocarditis. And the infection can also spread to the bone, resulting in the osteomyelitis. So these will be the complications which are associated with the pneumonia. Then how do you prevent? See, prevention completely depends upon what is the most common organism. So what is the most common organism? The most common organism will be Streptococcus. For that, you need to give vaccination. Now what is the vaccination that we give for the treatment of the streptococcal pneumonia? So because the most common organism causing lobar pneumonia and community acquired pneumonia is your Streptococcus, so you need to give the vaccine against this particular Streptococcus. And what is that vaccine? That is pneumococcal polysaccharide vaccine. That is what has to be given in individuals of age more than 65 years or in high risk groups. You need to give the pneumococcal vaccine. And another important organism that can be causing pneumonia is the influenza. So influenza vaccine also has to be given annually. But at the same time, you need to know which group of individuals require this pneumococcal vaccine or the influenza vaccine. Number one, the elderly individuals where the immunity is like reduced, and high risk groups like chronic heart, lung, liver, kidney, diabetics, alcoholism, and smoking. So in all these individuals, the immunity is like slightly compromised and the individual is more prone for infections. Next is the immunocompromised individuals like HIV, or the individual who is having malignancy, and these individuals who are having the asplenia. That means those individuals who have undergone splenectomy, the individual's capability against attacking the capsulated organism will be lost, and that will result in asplenia. Then those individuals who are having the cochlear implants, the CSF leaks, post splenectomy patients. So these are the indications for the pneumococcal vaccine, right? So pneumococcal vaccine and influenza vaccine, these are the two important vaccines that has to be given regularly, right, for these set of patients. So this completes the discussion of the pneumonia in detail. The next important topic in the discussion is the tuberculosis. So tuberculosis, which is caused by Mycobacterium tubercle bacilli, it is being transmitted to the person from one person to the other person by the following ways. That is by droplets, that's the main mode of transmission, wherein the organism, once it is being inhaled, either it will seed in the lung or in the tonsil or in the lymph node. And it can also be transmitted by the ingestion of the unpasteurized milk, and that will result in the development of the ileocecal tuberculosis, because there is rich lymphatic supply, that is Peyer's patches, at the level of the ileum. Then vertical transmission, the transmission can also occur from mother to fetus, and the Ghon's focus in the fetus, it is mainly formed in the liver, right? Or earliest or initial formation of the Ghon's focus will be in the liver of the fetus, because if you take the fetal circulation, first it will go to the liver. Next is by direct contact, and that we call it as the lupus vulgaris or the skin tuberculosis. So these are the four ways by which the transmission of the tuberculosis can occur. Then what are the risk factors for the development of the tuberculosis? So mainly the immunocompromised status, like the extremes of age, either you take in children or you take in the elderly individual. Next, the HIV, diabetes mellitus, silicosis, malnutrition, and as well as the immunosuppression. So these are the risk factors for the development of the tuberculosis. And next is the forms of tuberculosis. So when the individual is exposed to the organism for the first time, that we call it as the primary tuberculosis. And in case of primary tuberculosis, more than 95% of individuals, they are asymptomatic. Only less than 5% of patients, they are symptomatic in case of primary tuberculosis. Whereas you take the latent tuberculosis. Latent tuberculosis is that where the bacilli is present, but it is contained, right, where the organism is in a suppressed state. That is what is called the latent tuberculosis. And next is the secondary tuberculosis. So secondary tuberculosis is that where the individual which was contained or which was suppressed because of the immunity of the individual, now once the immunity of the individual is decreased, the organism gets flared up. That is what is called as the secondary tuberculosis, right? Then now, so reactivation tuberculosis is nothing but your secondary tuberculosis. And next, active tuberculosis, it can be either pulmonary or in the extrapulmonary sites. And next, what is the common clinical manifestation that you have in patients with tuberculosis is cough. And this particular cough is associated with expectoration. And this cough with expectoration will be there for nearly around 2 to 3 weeks. And the patient will have fever as well. And this fever, this will be a low-grade fever. Right, this will be a low-grade fever, and along with this low-grade fever, these patients will also have the night sweats, and there is also weight loss, and there will be decreased appetite in the individual, right? And along with that, there is hemoptysis and as well as fatigue. So these will be the common symptoms that you will have in patients with the tuberculosis. Then coming to the extrapulmonary tuberculosis. So if you take this extrapulmonary tuberculosis, the most common site for the extrapulmonary tuberculosis will be the lymphatic spread. So lymph nodes, they are the most common site for the extrapulmonary tuberculosis, and followed by that the serous cavities, that is into the pleura, where there can be development of the pleural effusion. Followed by that, then can be genitourinary tuberculosis, or there can be development of the tubercular meningitis as well. Then how will you diagnose this particular patients with the tuberculosis? So the investigation of choice will be CBNAT, right? That is cartridge based nucleic acid amplification test, and this we call it as the gene expert. right? So this we call it as the gene expert. So these are the diagnostic, and that is the investigation of choice. And apart from that, the other investigations include the sputum smear, but this sputum smear does not have a good sensitivity and specificity. And next is the MAN2 test. Like MAN2 test, you have many false positive scenarios where the MAN2 can be positive. Imaging, gene expert, and culture. And in the culture, the media that we use is the LJ media, that is called 𝐒𝐿𝐵𝐺𝐻𝑒𝐿 media. But this 𝐒𝐿𝐵𝐺𝐻𝑒𝐿 media, it will take almost 6 to 8 weeks for the culture to be positive. So what is that you need to do? The gene expert. And this particular gene expert, the another name for the gene expert is nothing but the CBNAT, that is cartridge based nucleic acid amplification test. And the importance of the CBNAT is that the CBNAT will also tell you about the rifampicin resistance. That is the importance of the CBNAT. Then what is the treatment? The first line anti-tubercular drugs will be the isoniazid, rifampicin, pyrazinamide, ethambutol, and then streptomycin. These are the first line anti-tubercular drugs. And the second line, you have some injectable agents. And these injectable agents include the amikacin, gentamicin. These are the injectable agents. Followed by that fluoroquines and as well as the ethionomides. So these are the second line anti-tubercular drugs. Now, what are the complications which are associated with the development of the pneumothorax? Number one, there can be development of hemoptysis, and that is due to rupture of the bronchial vasculature secondary to tubercle bacilli. There can be development of the pleural effusion. There can be miliary tuberculosis, where the organism is being spread from the lung to the distant organs. So the common site where you come across the miliary tuberculosis along with the lung, the organism can be spread to the kidney, the organism can be spread to the liver, the organism can also be spread to the spleen. These are the other sites where there can be miliary tuberculosis. Then followed by that, there will be development of pneumothorax as well, where there can be rupture resulting in the pneumothorax, and this pneumothorax will cause the atelectasis, and that is the hallmark manifestation in patients with the pneumothorax, and patients will present with sudden onset dyspnea. So these will be the complications. Then coming to the lesions that we come across in case of tuberculosis, one of the very important lesion that we call it as Ghon's focus. Now where do you see this Ghon's focus? Ghon's focus, it is commonly observed in the subpleural region, right? The Ghon's focus, it is in the subpleural area. Now what is the most common site for the presence of the Ghon's focus? The most common site for the presence of the Ghon's focus in case of the primary tuberculosis, it will be the lower part of the upper lobe or the upper part of the lower lobe. That will be the most common site for Ghon's focus. And what does the Ghon's focus contain? Attenuated bacilli, and there will be also the caseating granuloma. Then you take Ghon's complex. Along with Ghon's focus, if you see the same Ghon's focus in hilar lymph nodes, right? If you see the same Ghon's focus in the hilar lymph nodes, that we call it as the Ghon's complex. And so Ghon's complex, you have associated lymph node granuloma, that is called Ghon's complex. Then followed by the Ranke's complex. Ranke's complex is that the Ghon's complex, if it is calcified, that we call it as Ranke's complex. And where will this Ranke's complex be present? Either in the lungs or within the lymph node. Next followed by that Simon focus. Simon focus is that where there is reactivation of the tubercular lesion, and this reactivation of the tubercular lesion that occurs at the apex of the lung, and that is what is called as the Simon focus. Then followed by that the Asman focus. The Asman focus is that where you have the presence of the reactivated tuberculosis in the infraclavicular lesion. So the infraclavicular focus in the reactivated tuberculosis. So the location will be the infraclavicular region. Then followed by that the pulse lesion. So pulse lesion is that where you have the presence of the supraclavicular focus, and that is in the supraclavicular region. That will be the pulse lesion. Then followed by that the ridge focus. So if you take the ridge focus is that where there will be disseminated tuberculosis into the meninges resulting in tubercular meningitis. That is called ridge focus. Or the tuberculous granuloma which is present within the brain parenchyma that is spilled into the meninges resulting in the tubercular meningitis. Then next is the 𝐒𝐵𝐞's focus. 𝐒𝐵𝐞's focus is that where you have the presence of the caseating granuloma within the pulmonary veins, that is called as the Wiedger's focus. And in case of the miliary lesions, why is it called miliary tuberculosis? Because the lesions that you see in the lung will be equivalent to the size of the millet seeds, and that will be of less than 2 millimeters in diameter. And common organs where you have the miliary tuberculosis is liver, spleen, and as well as kidney. And what is the route of spread of the organism from the lung to the distant organs? That is by the hematogenous spread. And lastly, you need to be aware of the tuberculoma. Tuberculoma, it is a localized mass-like lesion with the central caseation, and that can be seen in the lung and as well as brain. So these are some of the important lesions that you come across in patients with the tuberculosis, right? And followed by that, the last topic is the ILD, interstitial lung disease. So you have various etiologies, and in patients with interstitial lung disease, the inflammation or the fibrosis is confined only to the interstitium of the lung. So these patients, they present with dry cough and exertional dyspnea, and the etiology mainly exposure to the cement industry, like causing asbestosis, and exposure to glass resulting in silicosis. And therapeutic causes for the development of the ILD include the radiation therapy for the malignancy, drugs like amiodarone and as well as methotrexate, which is used in the treatment of the methotrexate is used in the treatment of rheumatoid arthritis, and connective tissue disorders like rheumatoid arthritis, scleroderma, then polyarthritis nodosa, and dermatomyositis. Then granulomatous pathologies like sarcoidosis and hypersensitivity pneumonitis, and unknown causes like idiopathic pulmonary fibrosis, the cryptogenic organizing pneumonia, acute interstitial pneumonitis, and non-specific interstitial pneumonia. So these are all the etiologies that will be causing interstitial lung disease. Now, what will be the symptoms in these patients? They'll have dry cough and they'll have exertional dyspnea. So these two are the very important symptoms. And if you take the history in these patients, occupational history is very, very important, where when the individual is having the farmer's lung, or when the individual is having bagasosis, where there is exposure to the sugarcane dust, that will be the important occupation that will result in the development of the interstitial lung disease. Next is the smoking. So smoking will result in the development of desquamative interstitial pneumonitis and Langerhans cell histiocytosis. Followed by that, the autoimmune conditions can also contribute to the development of the ILD, and on examination, along with clubbing, you will have bilateral crepitations, and the type of the crepitations that you will have in patients with the interstitial lung disease will be Velcro crepitations. And how will you diagnose? That is by pulmonary function test, which will be a restrictive lung disease pattern. Next important is the imaging, that is chest x-ray and as well as the HRCT. So HRCT will show you that there is honeycombing or traction bronchiectasis. Next important is biopsy. So biopsy is the investigation of choice to tell you what type of the ILD is that. So fiber optic bronchoscopy with the cryobiopsy, that is considered as the investigation of choice. And what are the important ILDs which are associated with smoking? That includes desquamative interstitial pneumonitis and as well as the Langerhans cell histiocytosis. And how do you treat these patients with the ILDs? The treatment include the pirfenidone and as well as nintedanib. And non-specific interstitial pneumonitis, the drugs that we give is prednisolone, mycophenolate, and rituximab. And for connective tissue diseases, the drugs what we give is steroids. And in advanced cases of the interstitial lung diseases, you need to do lung transplantation. And some of the special syndromes include the Hamann-Ridge syndrome, where there will be acute interstitial pneumonitis mimicking the ARDS. Next, vasculitis, that is granulomatosis with polyangiitis, or eosinophilic granulomatosis with polyangiitis. Next, hypersensitivity pneumonitis like farmer's lung, bagasosis, and special syndrome. These are the special syndromes which will be contributing to the interstitial lung disease. So these are the important topics in the respiratory system for the quick revision. So this finishes the topic of the respiratory system quick revision. Thank you very much.